Hello,
Ma'am,
ma'am.
we are
Hello.
live
And
now.
Meena.
Sure.
Okay, okay.
We are live. Dr. Rashmi,
Yeah.
go ahead.
A very good evening, respected seniors and dear friends. It's a great honor to present before all of you the first webinar of Clinical Research Committee, Fox's Clinical Research Committee. The series is called E3, that is Excellence, Experience and Experience. And owing to the tagline, we would like to talk about all about LSS in the first webinar. I would like to request the chairperson of Fox's Clinical Research Committee, Dr. Surekha Tade Madam, to kindly introduce the and welcome chief guest
एक हफ्ते में आना है ना?
Thank you very much, Rashmi.
सीधा
Rashmi, the
admit ही
National
करना है.
Coordinator of
पहला
our
बच्चा है.
Clinical Research Committee, along with Dr. Nivedita Jha. And we are presenting a new series, actually, which is called as E3. So it is evidence, it is experience, and finally we are going towards excellence. So that is our series, and we are starting with a very burning hot topic, that is cesarean section, specifically optimizing cesarean section. As you all know, that Clinical Research Committee is has been given the opportunity by Foxy to do work on this very, very important topic of optimizing C-sections. And Foxy's flagship program has been optimizing cesarean section. And we are working on 50 sites actually where we are, these 4 interventions are going on. As you know, C-sections have been rising. We are seeing a rising trend and a lot of disparities among rural, urban, public-private facilities. And Government of India is now wanting that we as a big body, a huge body of obstetricians should take the lead and, drive this this very important agenda of optimizing C-sections. So today we are here with very important topics of LSA's audit and induction of labor, and then we'll have a panel on optimizing C-section with very renowned panelists. So our speakers, first of all, I would like to welcome our guests of honor, Dr. Madhuri Patel and Dr. Lakshmi Shrikande. And of course, my respects and, towards our Foxy president, Dr. Rishikesh Pai, who is presently in London, so is unable to join us. But we all know what kind of persona he is, how inspirational, how passionate towards maternal health, and specifically to this important topic of optimizing C-sections. So I would like to introduce to you our guest of honor, Dr. Madhuri Patel, ma'am, who is presently the Deputy Secretary General of Foxy and has almost all her life she has dedicated to Foxy. As you see, she has been on so many posts in Foxy. So that is almost 12 years she has been on the post in Foxy. And apart from that, being the first lady Secretary General, we have seen her mettle. We have seen how devoted she is. Presently, she is traveling from, I think, she's going towards Baroda for this run, this Samata
Gender
equality run. And you see that she is traveling, still she is with us. And throughout her 2 years and during her 3rd year also, we will be seeing her visiting not only big societies, but small societies, traveling by flight, traveling by train, traveling by road. So we see her visiting smaller societies, encouraging so she is now become that kind of figure whom we aspire to be like her, and definitely we would like to see her on the highest post of Foxy. Madam, we have few days ago, a week ago, I have heard your very, very inspirational talk on maternal mortality during the Femtech 4 conference, and I was really impressed by your knowledge, and especially regarding women's health, especially regarding this maternal mortality reduction. And we would love your guidance on this very important topic of optimizing C-section. Over to Madhuri, ma'am.
Thank you, Surekha, for such a wonderful and warm words. I must say that we all are doing great work as far as women's health is concerned. We all are dedicated. We are here. I can see Dr. Lakshmi, guest of honor. Then, we have Dr. Alka Pandey, right, to the vice president. And of course, Dr. Rishikesh, she is making us work for the women's health. So we are really encouraged that he has so many projects for all of us. We are working towards the reduction in maternal mortality rate as well as the on the women's health in general. So, we so respected Dr. Pai, Dr. Lakshmi, Dr. Alka Pandey, Dr. Sureka, Dr. Mitra, Dr. Sujata, I can see, Dr. Nivedita, Dr. Rashmi, I can see, Dr. Revati and others. Of course, other panelists are going to be there. Excellent panelists, Dr. Vidya, Sampat Kumari, and, all Charmila, Girja, and, one more, person is Dr. Revati. They and
Meena
Meena.
Samant.
Meena and all my dear friends, very good evening to all of you. As we are, marching towards, our goal, sustainable development goal of 2030 of less than 70 per 100,000 live birth. We are definitely going to reach much before that because many of our states have, achieved this goal, and we want our state who have achieved this goal, they should achieve a single digit maternal mortality rate by 2030. And of course the other states are also marching, and we are really happy that you people, the grassroots level worker, along with the Foxy organization and the government policies, we are really, really, really happy. And I really congratulate all of you as a grassroots level workers for achieving this, achievement. So I'm really happy for that. And of course, optimizing C-section is a very close to my heart, the topic. And, Sureka is doing great work with, 50, UNICEF is involved with this, and UNICEF is involved, and, 50, hospitals are involved, facilities are involved with the major hospitals. So I'm really happy we are going to really come out with a good data, which we can always show that, yes, we have optimized the C. Ek minute. We have optimized the C-section rate. So we will have good data, and we have to really modify our modifiable factors by putting a section, the knife on the primaries, especially what we are going to talk about. Mitra is going to talk about the cesarean audit, the induction of labor, and, optimizing, modifiable factors are most important for optimizing the reduction in the cesarean section rate, or optimizing the cesarean section rate. And they are especially labor dystocia, the induction of labor, non-reassuring heart rates, fetal heart rate, the cord around, single loop of cord around the day. CPD is to, taken a section without giving a trial. All these factors, if we look into it, we will definitely optimize the C-section rate. So Sureka and Dr. Alka and Dr. Rishikesh, all the best for your this webinar, most apt webinar, and I wish all of you the best of luck for the future endeavor. So thank you very much once again for inviting me as a guest of honor.
Thank you, ma'am. Thank you so much. And I think we would like to follow your footsteps and, be like you. I think all of us would like to aspire to be like you, so dedicated and so courteous also. A humble human being at the top. That is what is Madhuri, ma'am. And
Thank you.
similarly,
Sureka.
I would like to introduce another, very, very profoundly devoted person, that is Dr. Lakshmi Shikhande, ma'am. I don't even have to look at her CV here, and I can say so much about Lakshmi, ma'am. And Vidarbha region is so proud to have the first ICOG chairperson from Vidarbha. And not only Vidarbha, the whole of India is looking at her, the type of work she is being doing in ICOG. And I remember I was an assistant professor only. So just a newbie, and madam was already deep into Foxy, working, organizing events, organizing so many conferences at national levels. And she was a HIV chair, HIV AIDS committee chairperson, and I can remember her community work. I can remember her work in the schools. So madam has been doing extraordinary work And also I have seen her in isoparb also. So both ways I have seen her, especially I have seen her working in Foxy, dedicatedly. Day after day, I find another of her webinar, Chai Pe Charcha hai, Gurukul hai, Medha hai. So many things. Madam has been very, very, it looks so easy when she does it. But we know it is a hard work, and it is a dedication, and it is that perseverance, and she has been inspirational for all of us. And whenever we call her, that is another of our madam's quality, that whenever we call her and we send her a link, she is always there 15-20 minutes prior to us. And so I think that is one thing we will have to learn from her. We want to learn for her to be always before time, and to be always planned. And so we are with you, ma'am, and we would like to, so we love you. That is one thing we must say. And over to you for your guidance.
Thank you, Surekha. Thank you so much for those lovely words. Very good evening, dear friends. And I must say that just last month only we met at Femtech, and there we had a meeting of Foxy, UNICEF, and Ministry of Health and Family Welfare. And I must say here that Ministry of Health and Family Welfare were all praised with the work Foxy is doing in this area of optimizing C-section. I think Madhuri has just logged out, but with the vision of Dr. Pai, the president of Fox, Secretary General, and yes, of course, we need a co-person to work, and that is Surekha. With her dedication, perseverance, she is supervising all the 50 sites, and she is the link between Foxy and UNICEF and Ministry of Health and Family Welfare. We all know that there was a lot of hue and cry when WHO said that cesarean section rate should be 10 to 15%. Foxy came into forefront. Just can't have a fixed rate. So I'm so happy that everybody is talking about optimizing the cesarean section rate, which is the right word, because where it has to be done, it has to be done. And I was so happy that Surekha, who was person who came from Ministry and Family Healthcare,
Dr. Syed Ali.
Bipin?
Dr. Pawan Kumar.
No, from Ministry. Dr. Pawan Kumar.
Yes.
When he said there are some less C-section, like saying. So he was saying, no, those women need C-section rate, but there is some problem, and therefore the women who are in need of C-section, they are not getting it. So I'm so happy that he gave a very, very balanced view as far as cesarean section rate is concerned. No doubt, there is some commercialization at some places, but we can't generalize it. So I'm so happy that now we are working towards optimizing C-section rate. Surekha is our dedicated worker towards it. And today her whole webinar is on LSCS audit and optimizing C-section rate. So Surekha, I don't want to come between you and the audience and their happy learning, because this is really a burning hot topic. So I wish you all the very best, not only for your this E3 webinar series, but all the future endeavors of your life. And thank you so much for having me as guest of honor for your this webinar. Thank you.
Thank you, ma'am. Thank you so much. And I wish to be always, in that position where मैंने सिर झुकाया और आपने हाथ रख दिया. वो वाला position आप हमेशा बनाए रखें, and keep blessing us. Thank you so much for being with us. And I would also like to welcome our speakers, Dr. Mitra Saxena, Dr. Achla Batra. She's also joining on time. She has finished her C-section within 40 minutes. Yes. And we have our chairpersons, Dr. Sujata Dalvi. Then we have our another chairperson, Dr. Chaitanya Shembekar, our panelists, Dr. Vidya Thobi, Dr. Sampat Kumari, Dr. Shobha Gudi, Dr. Girija Wag, Dr. Charmila, Dr. Meena Samant, and Dr. Revati Rane. Also would like to express my gratitude to Rashmi and Nivedita. So over to you, Dr. Rashmi, for the academic proceedings.
Thank you so much, Surekha Madam. It's a great honor to proceed further with the scientific program of today's webinar on optimizing cesarean section. Bhavna? Bhavna, we would like to have Dr. Sujata Dalvi Madam's CV.
Yeah. Please start introducing as you know her so well.
Yes.
That's okay, even
The
if it's not.
chairperson for first session is none other than respected Dr. Sujata Dalvi Madam. Madam is secretary AMOX, and she is consultant obstetrician and gynecologist at various hospitals in Mumbai, like Global Hospital, Saipi Hospital, Bhatia Hospital, St. Elizabeth Hospital, and Ruxmani Jain Hospital. She is honorary clinical associate there at Navroji Wadia Maternity and Jagjeevan Ram Railway Hospital. Madam has been joint associate editor of Jogi and clinical secretary of Mumbai Obstetrics and Gynecological Society. More than that, it's a great honor to invite to chair this session to Dr. Dalvi Madam, who is very kind, compassionate, and very loving. I welcome.
I would just like to add that I have heard Madam in so many forums, and her knowledge, her scholarly attitude, and overall her, guidance to all of us youngsters. So, and Madam is, of course, evergreen and ever young. So over to you, ma'am.
Yeah. Thank you, both Rashmi as well as Surekha, for a kind introduction. At an outset, I would like to thank the organizer, especially Foxy Clinical Research Committee Chairperson, Dr. Surekha, for organizing this webinar on experience, evidence, and excellence. And of course, this would not have been possible without the able guidance of our evergreen Foxy President, Dr. Rishikesh Pai, and Foxy Secretary General, Dr. Madhuri Patel. I would also like to acknowledge the words of wisdom given by ICOG Chair, Dr. Lakshmi Trikhande, who is also very active. And I would like to acknowledge the efforts made by today's coordinator, that is Dr. Rashmi and Dr. Nivedita, for organizing this webinar. At an outset, it's my privilege to introduce our first speaker. That's Dr. Mitra Saxena. Of course, everybody knows Dr. Mitra Saxena. She is a very good speaker, a good academician, and
Bhavna, please put forward.
yeah, and she's been
Mitra Madam, this slide.
Yeah, just put Dr. Mitra Madam's slide. Yeah. She's a senior consultant in private practice in Rewari, that is Haryana district. She's been currently the Foxy Practical Obstetrics Chair Committee Chairperson, and she has been a past president and new patron of a Rewari Obstetrics and Gynec Society. She has been convener of various projects. She has been very active so far as Foxy Practical Obstetrics activities are concerned. And she is going to be talking to us on LSCS audit, the Robson's criteria. Mind you, Dr. Robson was with us in a Femtech 4 conference in November in Mumbai. Many of us had an opportunity to meet him and talk to him. And I'm sure Dr. Mitra is going to do justice on LSCS audit, the most talked about so far as C-section is concerned, but people don't realize that maternal mortality has decreased so much. So in turn, there has to be a little bit increase in the rise of a C-section, and we are trying to justify the audit for the rise in the C-section. So over to Dr. Mitra Saxena for LSCS audit, Robson's criteria.
Thank you.
Stop sharing this one. Yeah.
Just thank you so much. Actually, I'm really, really honored by the presence of Dr. Madhuri Patel and Dr. Lakshmi Trikhande. And of course, our president, who actually has made sure that all of us increase our momentum, speed in learning and in disseminating knowledge. And thanks to all these seniors and Foxy, who do themselves really good, job themselves and inspire us to do the same. And I'm really grateful to Surekha to give me such a difficult topic. So at least, it is a step for me ahead as well to learn everything firsthand. And I hope in the next 20 minutes, I will be able to do justice to explain what is this LCS audit about. So thank you. Just 1 second, I want to minimize the whole thing.
उल्टा चलना भी सिखा दिया आपने.
Yes, thank you so much.
Thanks से ऊपर आ गए. चलिए.
पीछे से चले ना. Anyhow, so without much ado, the next 20 minutes, I would like to take you through what this LSCS audit and what is this Robson's classification, which all of us who are, whether we are in a small setup or in a big institute, all of us should know everything about it. So I bring you greetings from Rewari, and what my talk today would be, I would like to take you through the Robson's classification, understanding and assigning groups, doing some exercises, explaining what the audit is all about and how to interpret it, and if time permits, then do some challenges. So we all know that rising cesarean section rates are a major public health concern, and there should be a classification system to monitor and compare cesarean section rates. It's not important enough to justify, but also if we are able to compare that in this facility, this is the rate and what is the reason. So we have to actually go about doing good practice as well as be able to monitor our practices. So there was a need to have a tool to compare cesarean section rates in different settings, in different times. And this is, it has to be reproducible. And also, it has to be internationally applicable. That is the beauty of Robson's classification, because we had, there was an overall cesarean section rate, traditional way of finding the cesarean section rate, but which was having so many variables as depending upon the infrastructure, hospital factors, differences in the characteristics of the obstetric population or the clinical management protocol. So there was nothing uniform. But this, we needed a simple, reproducible, clinically relevant, accountable, and some modality which be verifiable and internationally applicable. So we had this Robson's classification, and now we all know that WHO has promoted it, accepted it, understood, and would want all the middle income, low income, and even the high income group countries to go ahead and do their audits and assess their own practices. So the beauty of this classification is that this is not only a rate of cesarean section. It is every woman who admits to the delivery facility can be classified into one of the 10 groups. So this first point to understand is that this is not a classification only for cesarean section. It is all women who deliver at a specific setting, and means that the vaginal as well as cesarean section. This is the point number one. Now we have to understand that once we go through the whole chart, how we do it, we will understand that this is a very comprehensive perinatal classification, and this can be used prospectively. That means whenever a woman gets admitted in the facility, she can be assigned a group. And there are two very, very important terms which I would like to take a minute to explain, that this is a mutually exclusive classification, which means that every woman who comes into a facility will be assigned to only one of the groups. She cannot go into two groups. So if we understand how the groups are, assigned, we understand that every patient will be in only one group, but every woman will find a place in one or the other group. So it means this classification is totally inclusive and mutually exclusive. Now, what we have to understand is what are the variables on which all these group assigning will be done. It's very simple. When we used to write a patient comes gravid at this, full term, in labor, with previous cesarean, with multiple, with breech or all. So we used to have a long, diagnosis before we entered the patient. So basically, this is so comprehensively done that one of the variable is parity, nully, and multi. I will not go into the details because it's very elaborately done. Second important point is onset of labor. Now, this is really, really important, because we realize whenever we admit patient in pre-labor, that is the time that the incidence of cesarean automatically increases because our inductions fail or it is a pre-labor cesarean. So onset of labor is really very important variable to be considered. Next is a cesarean section. Any multi, because this is automatically a primary, will not fit into this category. So all patients who are having previous cesarean, this is a very important variable. Next comes the lie. So all cephalic breech transfers, they will be classified. Number of fetuses, again, they are going to have different outcomes, so single or multiple. And another variable, core variable, is the gestational age. Whenever it is preterm, less than 37 weeks, and term more than 37. See, the idea is these 6 core variables, if we have them in place in our mind, we'll be able to assign a role. Actually, I'm not going to go into details in this graph, but I just want to say it's beautiful diagrammatic. This means spontaneous labor. This means induction. So 1 and 2 is for the nullipara. 3 and 4 is for the multis. There is a baby along with the mother. Again, this is spontaneous labor. This is induced labor. Now, group 5 is a patient with cesarean section. Then group 6 is breech. You can see the breech here, and it's a primary, no other baby. 7 is again a multi with breech. 8 is a very important. There is multiple pregnancy. 9 is any other lie, which is transverse or oblique, and 10 is a preterm. So I wanted just that everybody should look at these things, and we all have to understand that once we classify the patients, whoever comes in our facility, we'll be able to identify and analyze the groups of women which contribute most and least to the overall cesarean section. Because basically it was developed to, find out this. However, we find that this also tells us the total number of deliveries, what are the trends, whether cesarean is more, or what is our practice we can make out from the way we have more vaginal deliveries or more cesarean sections in different groups as per the 10 groups is there. So basically, it does a lot for us to understand our own obstetrical practices. So, and the best thing is that it doesn't matter where you are practicing, whether you are in a single setup or you're in a bigger facilities, this applies to every system, and you can analyze your data, provided you understand the basics of how to assign the group to a laboring woman. Now, there are challenges. There are challenges to it, which is missing data, misclassification, and some lack of definitions. And I'm sure with robust practices of inductions of labor, when to call it as failed labor, we will be able to still refine our practices, and then assigning the groups will be very easy. So I do not want to spend more time on this. Now, I would like to see, as I said already, group 1 and 2 is of 1 is and 2 is of nulliparous. So 1 and 2 is nulliparous in labor, 2 is induced labor or pre-labor, 3 is all the multiparous women, and 4 is with not in spontaneous labor, but those who are going to go for induction. 5 is to remember for cesarean section, 6 for a breech primary, 7 is multi, 8 is multiple pregnancies, 9 is transverse oblique, and 10 is these different. So now to remember, I would go, there are 2 slides. One is we go through 8, 9, 7, 6, and 10. And the other was 5, 4, 3, 2, 1. So let's go. Let's look at who will be in group 8. So group 8 is all the multiple pregnancies. All twins, whenever they come, they will be assigned to group 8. Now, all women who are transverse live will be assigned group 9. And all breaches, if they are multiparous, then group 7. And if they are primary, then they'll be in group 6. Now, coming to 10, all single cephalic patients who are gestational age less than 30. So here, when we talk about gestational age, we are not considering the breaches and the transfers, because if the breach or transfers is there and it is less than gestational age, already they have been assigned to a group. So you understand that every patient would already find a place in which group it is going to be sitting. Now, coming to 5, 4, 3, 2, 1. So all term cephalic more than 37 weeks, if they are multiparous and previous cesarean, that is group 5. Now, coming to all the multiparous who have to go for induced labor or pre-labor, they will be in group 4, and who go in spontaneous labor, they will be group 3. Those who are nulliparous who go into induced labor, it is group 2, and who in spontaneous, it is 1. So very easy. 1, 2 is nulliparous, 3, 4 is multiparous. And again, the odds 1 and 3 are spontaneous labor, 2 and 4 are induced labor. So these are 2. Now, this is a very important spreadsheet. Now, software has been developed. So ideally, you do a hand count and you make all the 6 variables, and once you fill up all these tick, 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 you will automatically get the number of patients in group 1 who will be all primaries, no, they are in spontaneous labor, single cephalic more than, and term gestation. So you understand this is a very important spreadsheet, which when converted and used along with a software, will automatically give us the total number of patients in every group. So having done this, if there is time, Dr. Surekha, can I take them through some exercises?
Yes, yes, surely, surely.
Okay, so now see, on the left we see there is a cesarean section which has been performed in a patient of nulliparous fetal distress who had come in spontaneous labor with a single 10 cephalic presentation at term. So see, we see nulliparous, so it has to be an in spontaneous labor and it's term. So three things are fulfilled, automatically it goes into group 1. Right, so this is actually just to make it simple where we will place this patient, nulliparous, spontaneous labor at term, so group 1. Suppose if this was not term, but suppose it was at less than 7 weeks, it was single cephalic, nulliparous, multiparous, whatever. But if she goes into fetal distress at less than 37 weeks, this would have been group 10. So now coming to another exercise, we have a prior vaginal. So this is a multi at 41 weeks. She has been admitted rightly for induction of labor. So what will be her group? Definitely she'll be either in 3 or 4 because she's a multi. Now she's for induction. So definitely she will be in group 4 because she has to be induced. So I hope I'm right. Yeah. Again, now if we just change the permutation combination, if she doesn't go in for cesarean and she delivers normally, also she will be in group 4. This is what has to be understood, that every laboring woman will find a place in one of the groups, whether she delivers vaginally or she delivers cesarean section. I hope that is clear. Now coming to this nulliparous breech, who actually was more than 37 weeks and she had external cephalic version. After successful external cephalic version, she was immediately induced labor and she delivered cephalic presentation vaginally. Now, where does she go? Basically, she's a nulliparous woman, more than 37. Somewhere here she has to go. Now, from breech, she was not delivered as breech, she is delivered as a cephalic and she has gone through induced labor and she's delivered vaginally. So fine, doesn't matter. She goes into group 2. Even if she had gone in for cesarean, she would go into group 2. She has delivered normally, she goes into group 2. So that is the understanding we all must have. Now I think we could do more exercises, but I think what is important is to understand the audit. And actually we can test ourselves. We can just make any permutation combination, any case, and then assign which group this patient goes, whether she delivers vaginally or cesarean. That's immaterial, but the group will be well assigned because we have to remember it's mutually exclusive and totally inclusive. No patient will be left out from this 10 group. Now, coming to the audit, I want you to understand this is a very, very important spreadsheet. If anybody wants to take a picture, this is the time. So there are 7 columns. Now, this is every column is very important because column 1 tells you the group we are dealing with. Suppose it's group 1. So all group 1, that means all nullies, more than 37 weeks, cephalic, they will, all those who come into spontaneous labor, their number will come into group 1. Now, column 2 will be in this group, all the patients who undergo cesarean section, they will be mentioned in the column 2. Now, in column 3, we will have the total number of women delivered in this group. So in this group 1, all the nullipara who are term, who have gone into spontaneous labor, and they are cephalic. So if they deliver by cesarean, they go into column 2. If they go through vaginal, then they will be a part of this because this is total number of women delivered in each group. So this group will have vaginal plus this group. We have to understand column 3 will have total number of women delivered in each group. So each group will have a vaginal as well as cesarean. So we have to understand column 2 is only the cesarean in that group. Column 3 is cesarean plus vaginal. Now coming to column 4, which is going to tell us the relative group size to overall facility population. So facility population will be an addition all the deliveries in all the groups. That will be the total delivery. And what is the relative group size to overall facility? So now let's look at the thing. The group size will be the number of women in the group here and total number of women delivered in the hospital. So column 1 divided by the total number of delivery in the facility, that will give us column 4. Now coming to column 5, which is cesarean section rate in each group. We already know these are the sections in this group. So for each of the 10 groups in percentage. So cesarean section rate in each group will be number of cesarean section in this group, that means column 2, divided by total number of women in the group. So the total number of women, in this group will be giving us the cesarean section rate in that group. Now coming to column 6, which tells us the absolute group contribution to overall cesarean section rate. So overall cesarean section will be an addition of all the column 2s. See, the column 2 will be all the total cesarean in this group and as well as in the all the rest of the 10. So the total number of cesarean will be addition of all the column 2 and absolute group contribution to overall cesarean section rate will be calculated by the number of cesarean section in this group over total number of cesarean. That will give us the column 6, that is the percentage. Now relative contribution of each of the 10 groups to overall cesarean section rate is going to be calculated by number of cesarean section in this group, that means column 2, and total number, that is this total number of cesarean section. So this is really important, because if once we complete the whole chart, which I'm going to show you now, this is the whole spreadsheet where every group has been filled. So what I showed you in this, which was one group only, now here is all the 10 groups together. And so we have the same thing of all the groups. And this will give total number of cesarean section. This will give total number of women delivered 100%, provided all have been assigned a group. Suppose for some reason, some patient doesn't find a place, that will be the missed data. Again, the group size, total all. And so as I described, every group will have their group cesarean section rate, absolute contribution to overall cesarean, and relative contribution. This is very important because this is actually very standardized data. And so we know that how many patients comprise one group and what is the total number of women delivered, what's the total number of cesarean section, overall cesarean section. Now, what is very important to understand is why are we looking at all this? Because this is going to help us in understanding the quality of data that we are dealing with. Now, and also it will also tell us the type of obstetric population and of course the assessment of the cesarean section. I have plenty of slides. I don't want to, I'll just try to show you assessing quality of data. Now, come on, if we look at the group 9, which was transverse lie, we know that in transverse lie, our cesarean section rate should be 100% by convention. So if when we are analyzing the data, our cesarean section rate is not 100% or less, then maybe it could be because some baby's IUD transverse lie and it has delivered vaginally, or some internal version has been done. So that is important. That another thing is, we all know that we don't have very high incidence of transverse lie. So incidence of transverse lie is going to make up the size of the group. So this is what is the importance of analyzing when we try to assess the type of population. Similarly, we were supposed to look at, I would say, let's go to column 6 and 7. Column 6 and 7 comprises of all the breaches. We all know that the incidence of breach is 3 to 4%. So when we analyze our data, the number of patients who are coming as nulliparous, breach or multiparous, the data should not be more than this percentage from the total number of delivery. That's how it is important, because some of it is our own knowledge and then is interpreting it in the context of having assigned the groups into different having assigned every patient to a group. Similarly, if we have a big size of group 10, that means preterms, it means it could be a high risk, tertiary care where you're dealing with smaller babies, FGR. So looking at the data, we can make out what is the kind of practice. But suppose we are not having, our data is not coming true to what is our facility provided, we can actually analyze that as well. Now let's the other thing is to assess the cesarean section rate. So most important, I would like to say, because the time is running short, that whenever we look at the cesarean section rate for group 1, which we all know, this is the primaries where we can save every cesarean as much as is possible. So if it's a high cesarean section rate, it means that there is something inappropriate. So we have to have an acceptable cesarean section rate, that is robust practices for vaginal birth. So looking at cesarean section rate for group 2 means our induction practices. Are we doing good justice to the fair inductions, timely inductions, or it is some other reason which is defining our increased rates? So these actually, friends, All these are beautifully given in the document of WHO manual. I just try to simplify, but most importantly is that if we look at, this is the slide I wanted to spend 1 minute. See, if we look at the relative contributions of group 1 and 2, which was the primees, spontaneous labor and induced labor, group 5 was all the previous cesarean sections. So this adds up to 2/3 of the total cesarean sections. If we are overshooting or undershooting, it implies our practices. So basically, if we are trying to decrease our cesarean section or optimize them or justify them, these are the most important groups we should focus. Again, for example, if in group 5, which is previous cesarean, and if a center has a higher incidence of TOLAC, definitely our cesarean section rates in group 5 would be slightly lower than what is acceptable. And this, as I said, look at the absolute contribution of group 5. This is actually, it is responsible for 28%. If it is very high, it means that in previous years, lots of cesareans have been done. So this is overall incidence is high. Now, there are barriers and facilitators to implement the classification. The ideal thing would be for the lead person to understand themselves and then designate, train, make a person in charge. Initially, hand-holding is needed, but basically one spreadsheet where all the groups can be easily assigned. And one is the audit sheet where once all the patients have been classified in the 10 groups, then we look at the spreadsheet and understand the audit so we can always calculate our own rates. The importance of all this is that if somebody, of repute asks us offhand, I'm in a private setup. I don't have a very big delivery load, yet it would be good if I'm able to immediately tell, this is my induction rate, this is my cesarean section rate, rather than just fumbling and trying to say this is about this much. So that is the advantage, that once we look at the quality of data, we also misclassification. See, misclassification is that if some group could not be assigned a proper, place because of some lack of information. So we have to make sure that all these things are fulfilled in our documents. This is really, really important, friends. And thank you, Dr. Sureka. Thank you, Foxy. Over the last couple of 2-3 months, we've all been reading about cesarean section. And I would say the journey of 1,000 miles begins with a single step. If we begin to understand what this classification is about, I actually really felt like bowing my head to Robson, because this is also transitioned. It was initially thought to be cesarean section, but now having understood it, this defines all the deliveries. So I think it is a fantastic document. And every one of us, even if we have low workload, we can compile data for 6 months or a year and feel confident that, we are doing good practice. Thank you so much. I'm sorry I've overshot by 10 minutes or so, but thanks for allowing me.
Thank you so much. Over to you, Dr. Sujata.
It was,
thanks, Dr. Mitra, for absolutely clarifying the Robson's criteria. And I'm sure everybody has understood that whether patient delivers by C-section or vaginal delivery, she belongs to only one group and doesn't belong to 2 groups. And how group 1, 2, and 5 are very important so as to keep a tab on your C-section audit. In fact, to be very frank, in a public hospital, there is one more column which has got added for any patient who delivers, whether she belongs to which type of a Robson's criteria. So people have started auditing the mode of delivery with the Robson's criteria.
Ma'am, there is actually in column 1, 2, 3. In column 3, there is total delivery. So 2 has got cesarean. The rest are understood they are vaginal delivery.
Correct.
One thing I wanted to point out, Dr. Sureka and all the, big wigs, that one place I found we cannot classify, especially if we have a multiple pregnancy and then one baby delivers vaginally and the other baby delivers by cesarean section. I really wanted to ask this question to Mike Robson, how to classify that.
But then finally we have a C-section, isn't it?
Yeah, of course.
So we have to understand that.
But every group is also further divided A and B. I thought this.
In fact, even the paramedical staff has been told how to put it into a Robson's criteria. And Manyata, training program also teaches all the paramedical staff to how to classify a patient according to Robson. So thank you so much once again Mitra, for explaining and
Yeah.
making it so simple, the wrong
I
way.
also want to add my words of gratitude to Dr. Mitra, especially making it so simple and giving us those small practice examples as well. And yes, I would like to reiterate one thing, that it is about classifying all deliveries, not C-sections. All the deliveries are going to go into one group of the other, and then we'll calculate the rates, absolute and relative contributions. So that is what we should understand. So because many of the some of the healthcare workers are asking me whether we are classifying C-section. It is not so. We are classifying all deliveries. So we underline that thing again and again, so that definitely in recent future, all of the healthcare workers will be trained, and we will be auditing our processes later on, what we are doing, inductions, what we are doing, when, how, all those things will come. And for that, we have our next talk, and over to Dr. Rashmi for the same. Welcome, Dr. Achla, ma'am, in spite of your, very hectic afternoon, and hope that everything is fine during the cesarean section which you conducted.
Yeah. Thank you. So
over to Dr. Rashmi.
Yeah.
Thank you so much, Surekha ma'am. Thank you, respected Dr. Sujata madam and Dr. Mitra Saxena madam, for this very informative session, and special thanks to Surekha madam for valuable inputs into the session. And it's a great honor to invite Dr. Achla Batra madam for her talk. I would like to humbly invite Dr. Meena Samant madam to kindly chair this session. I would like
good evening, everyone. And it indeed is my pleasure to introduce Professor Achla Batra. We know she is the National President of NARCHI, the Governing Council member elect for Foxy ICOG, and Chairperson IHCP Division Stillbirth Society of India, member Foxy Project on Reducing Caesarean Section. And that is so important for today's meeting, and I think she's going to highlight on one of the very important aspect of in relation to that only. So Dr. Batra, who has so many accolades, she's very experienced, and she has been the president of AOGD only recently, and we saw what wonders the society had done. So ma'am, over to you. We all are keen to listen to you on induction of labor.
Thank you, Meena. Thank you for your kind introduction. I think I need Mitra to stop screen sharing.
Yeah, till that time, I would like to introduce Dr. Meena, respected Dr. Meena Samant madam, to the house. Madam has been chairperson of Foxy's Clinical Research Committee, and she is president of Patna OBGYN Society and vice president of ISOPA. She is a senior consultant and HOD at Department of OBGYN at Kuji Holy Family Hospital, and we specially acknowledge and thank her for her help at the time of starting our Vidarbha ISOPA activities. We welcome you, ma'am.
Okay, good evening, everyone. And I'm going to talk about induction of labor. And I'm sorry, my slides may not be up to the mark because last 2 days I was busy with my daughter-in-law inducing her. And finally, she had a section. So what is induction of labor? Induction of labor is a process of artificially stimulating the uterus in order to start labor. And we have to understand, there's a difference between induction and augmentation. Augmentation is when somebody already has contractions and you do something else to increase the contraction, and ripening is a part of induction when the cervix is unfavorable, so that you are able to ripen the cervix before you give pharmacological agents to increase the contractions. So what is a successful induction? When this is very important to us because so many cesareans are done because of failed inductions. So one has to know when a vaginal delivery occurs within 24 to 48 hours of induction of labor, depending upon the facilities you have, or the woman reaches active phase of labor in 12 to 24 hours. If this doesn't happen, then you say failed induction. And if there is a failure to achieve regular contractions after completion of a cervical ripening consisting of 3 intracervical gels at 6-hourly interval, or 12 hours of oxytocin administration after rupture of membrane, or having given one pessary and nothing happens. Several societies have established recommendation and clinical indication for methods, but still so many inductions are taking place which are not indicated because somebody wants to shorten the duration of pregnancy or wants delivery at a time. And this kind of inductions, they intervene in the natural process and can lead to complication like bleeding, cesarean, hyperstimulation, rupture, and poor outcome. So WHO says that IOL should be performed only in cases there is clear maternal or fetal indication and the benefits outweigh the harms. So what are the indications? We all know, I think, post-dated, premature rupture, pre-labor rupture, hypertensive disorder, medical conditions like diabetes, fetal death, or a previous IUD at term, FGR, chorioamnionitis, multiple pregnancies, vaginal bleeding are circumstantial when somebody stays so far away that she cannot come at time of labor pains. So sometimes we have to do elective indications. And ACOG, SOGC, NICE, WHO, they all endorse it, but in clearly the document, only SOGC writes about all the indications. WHO only writes about, post-term and premature rupture of membranes and fetal death. ACOG doesn't write about uncomplicated twin pregnancy or IUD in previous pregnancy. But SOGC, which has come up with the latest guideline in 23, writes about everything. Now, when do we induce labor? That is very important. So we have to know if there's FGR, no abnormal Doppler, then it is 38 to 39 plus 6. If there is absent endosteric flow, then 34 plus 0. If there is reverse, then you can even induce at 32 if feasible. Otherwise, you do a cesarean. Chronic hypertension, not on an medication, you can go up to 39 plus 6. Gestational hypertension, 37 plus 0, or later if the diagnosis comes late. Preeclampsia without severe feature, again 37 weeks. With severe feature, 34 weeks, or at any time when there is a complication or whenever the patient has come. Diabetes, which is well controlled, even if it is pre-gestational, you can go to 39 plus 6. GDM, again 39 to 40. PPRM, now the indications have changed. Previously, we were doing it all at 34 weeks, but and all this has been given by ACOG, SOGC, NICE, WHO. They all endorse it, what I have said. Then a word about post-dated pregnancy. It is, the commonest indication when we are using WHO, NICE 2021 guidelines, SOGC 20, they all say 41 is the time to start induction. 42, nobody now says. And NICE also between the lines says, though they haven't put it in the guidelines, they say that the studies have shown that Asian women or women from, African country with low socioeconomic, their maturity occurs at 39 weeks. And when they have delivery at 40 weeks, they have more complications than when they have delivery at 39 weeks. So at least in India, if not at 39, we should be very, very careful at 40 weeks that if we are waiting till 41 weeks, we have to do the monitoring, which is done in Western countries from 41 to 42. We have to do that from 40 to 41 weeks. Like I said earlier, PPROM. Now, if PPRM occurs, we like to manage expectantly unless there is infection, and you can go up to 37 weeks. And if it occurs between 34 to 37, again, you have to discuss with the woman now that she wants induction or she wants to go till 37 weeks. And pre-labor rupture, already said 24 hours. And if there is some infection, GBS, on the complications, then immediately. This is a flow chart. You can see if membranes are ruptured or not ruptured. If we don't have so much GBS, so if membranes are ruptured, GBS positive, of course, you have to induce. Otherwise, you can do expectant management up to 24 hours, that is pre-labor rupture of membrane. And if it is not ruptured, then everything depends upon the Bisher score. We'll talk about it later. Contraindications: vasa previa, transverse lie, cord prolapse, previous classical, genital herpes acute, previous myomectomy entering the cavity, pelvic structure deformities, CA cervix. So we have to know that these cases don't have to. So what are the methods we have? We have non-pharmacological, just sweeping, stretching, ARM, mechanical balloon or hygroscopic dilator, pharmacological, oxytocin, misoprost, dinoprost, gel or pessary. Other things like castor oil, nipple stimulation, breast compression can reduce the need for labor, may be offered to low-risk population, but there is no evidence for that. Now, some guidelines say that these are the things which should not be used and which is included intracervical dinoprosteron and intravenous oxytocin alone. But I personally feel that we don't have that kind of monetary thing that we give don't give intracervical dinoprosteron when required, and intravenous oxytocin alone also they say should not be given, but we do give it when the cervix is favorable and do the ARM later. So the Western guidelines say that you do ARM and then give oxytocin and don't give oxytocin alone. Prerequisite, very important. Does the place has trained personnel? Do they have things to monitor the baby? Do they have cesarean section facilities? And also informed consent must be taken. Assessment is very important. Date, any heart disease, asthma, liver or kidney disease, previous uterine surgery, obstetric surgery, to see that what drugs can be given, what cannot be done. General physical examination must be done. You must assess the level of the head, whether it is fitting like is not an oblique lie. And if you are not sure, you can do an ultrasound and record the Bishop's score. Very, very important. Of course, fetal heart has to be seen and no contraction should be there. If there contraction there, if you're not inducing. The Bishop's score, I'm not going to discuss. I think we all know that a favorable score is 6, though SOGC says the favorable score is 7 and unfavorable is 1 to 5. Sweeping and stretching, the recommendation now have changed, from previous recommendation. Previously, it was said that sweeping, stretching, there was controversy, but now SOGC says that primaries, you do sweeping once at 38 weeks if possible, and then you can repeat it at 39 weeks. NICE says that all women, if possible, do sweeping at 39 weeks. Of course, patient has to be explained that she'll have little pain, she may have little bleeding, and there is a chance that she may have rupture of membrane, very little, but she has to be explained and doesn't really happen. And have to even ask them if they would be willing for a second sweep if you're done at 39 weeks. If the cervix is unfavorable, then we have pharmacological methods and mechanical methods. And mechanical methods are really good if it is feasible to do it, which are intracervical balloons or hygroscopic dilators. They are the first line if possible. Pharmacological, we have misoprost, prostaglandin E1, which can be oral or vaginal, or E2, dinoprost, intravaginal gel or pessary, and also intracervical gel we are using. And these guidelines say that oxytocin alone should not be used as a cervical ripening agent. I think we all agree to that. Should not use oxytocin just for cervical ripening. This is first line SOGC, and even NICE says that mechanical are the first line. You can even do it in previous cesarean patients. They are also advocating that you can do outpatient ripening after doing NST, put in the drug, either misoprostol or dinoprostol, do another NST. If it is okay, she can be sent with the instruction what all, that if she starts contraction or the baby is not moving much, or if she has leaking, she should come back. And sometimes, you are doing induction when you're not in a hurry, but patient has to be induced. They even say that after giving the misoprostol, 2 hours after that, you can send, and 4 hours after a vaginal dose of misoprostol also, you can send the patient home after electronic fetal monitoring is normal. Now, what are the induction methods with a good Bishop's? Oral prostaglandin or intravenous oxytocin with amniotic. These are the two best methods. You can use misoprostol concurrently or sequentially with a balloon catheter. You can even use dinoprostol gel to induce labor, even when the bishop is more than sound. Amniotomy can be performed as a method of induction once the modified bishop score is more than 7. But amniotomy is most effective when you combine it with oxytocin. Misoprostol has been, in all over world, it is being, said as the best agent, but I think we still don't have FDA approval. But it is safe, easy, especially if you use it, judiciously, starting with the minimum dose of 25 or 50 and not more than that, and then titrating it. Those can be started after dissolving the misoprostol tablet, or if you have 25 microgram tablets, you can start. And every patient has to have a customized regimen like in oxytocin. And after giving miso, you do monitoring electronically for 20 minutes. If it is all right, then if she is not in labor, then you ask the patient to move about till the next dose. And the next dose is, if you're giving oral, it is 4 hourly. If you're giving vaginal, it is 2 hourly. When the signs of active labor present, establish again electronic fetal monitoring and continue ambulation. And once the patient goes into active labor, you can even give IV if required. And once the membrane rupture, then also you can continue misoprostol. You don't have to shift from misoprostol to oxytocin, just continue with the misoprostol. And according to the Cochrane review of 2021, the best available evidence is that the low-dose oral misoprostol has many benefits over other methods of labor induction. And they say there is very low risk of hyperstimulation when it is given vaginally. And still oral regime, still we need to optimize the dose, but vaginal, there are no much side effect, and the starting dose is 25 microgram. Oxytocin, we all know every institute have their own policy to give how much oxytocin they give. You can have a low dose regimen, begin with 1 to 2 milliunit and increasing every 30 minutes, or you can start with a high dose regime, beginning 4 to 6 milliunit and increase every 15 to 30 minutes. Though high dose protocol reduce the induction delivery interval, but there is a higher risk of tachysystole than low dose. And maternal fetal complication are seen. You have to record oxytocin if you are giving, and you have to record in milliunits per minute, and you have to have continuous monitoring. This is dosage. I mean, I don't need to discuss. I think you all know that how to prepare oxytocin. Like 500 ml, if you put 2 units and start at 8 drops, you get 1 milliliter. So, and you can keep increasing. The maximum dose is 50 milliunits, and you keep increasing till the uterine activity reaches 200 to 250 Montevideo units, and patient has a uterine contraction lasting to 40 to 45 seconds and a minimum of 3 contractions. Upper limit, I told you, is 40, and some guidelines recommend that once good contractions have established, you can decrease the dose of oxytocin. When you have to start oxytocin, at least 30 minutes should have elapsed before you have removed the dinoprostol vaginal or insert. 6 hours post vaginal gel or intracervical gel, 2 hours post misoprostol oral, and 4 hours post vaginal. And these are very strong recommendations. And combined methods are, they show better results, like you give ARM and then start oxytocin, or you give dinoprostol and the patient has good cervix now, then you can follow with oxytocin if the contractions are not established 3 contractions in 10 minutes of good duration, or you can use mechanical methods and then follow them with misoprostol or oxytocin. Monitoring is very important. When uterine contraction begin after administering dinoprostol, misoprostol, or oxytocin, you have to assess fetal well-being and contraction with the CTG. If CTG is normal, then if it is low risk, you can shift to intermittent auscultation. If there is abnormality in the fetal heart, or if there are excessive uterine contraction, then you restart cardiotocography and do not give any more doses. And if pessary has been given, it should be removed. And if gel has been given recently, you can even wash it. And the complications which can occur are hyperstimulation, for which I said you can stop infusion, remove the pessary, and wash the cervix. Tocolytics can be given. And you have to know that the patient should not be having any cardiac disease when you're giving beta mimetics. And if there is abnormal fetal heart pattern which are persisting, then you have to deliver the patient. Rupture normally doesn't occur with unscarred, but we have seen ruptures with multiple pregnancies, malpresentations, or aggressive use of uterotonics in unscarred uterus also. Previous cesarean section, higher risk, 4 times higher risk. So you have to keep a close watch on maternal signs and fetal heart rate monitoring. And failed induction, we've already talked about that. What is the criteria? And failure of labor progress and failed induction are two things. If a patient has gone into active labor by or inducing method, then it is not failed induction, then it is failure of labor progress. The most important thing when you're inducing is pain relief. The pain relief option should be informed to the woman, otherwise you'll have so many women opting out of induction because of pain. Relief can be simple analgesics, epidural, you can use pethidine, opioid analgesics, and it is not necessary that patient should be in active labor, should have reached 4 to 5 centimeters before you give epidural. You can give it earlier also, and she should be encouraged to use breathing and relaxation. Even with my daughter-in-law, though she had a cesarean, but after the pain relief, she really had a good time for 7-8 hours and progressed within 7-8 hours. So other thing is, patient must be counseled when you are inducing her, that why we are inducing her, what are the risks and benefits, what method we are going to use, what are the other alternative method available, and we will be using electronic monitoring, what is the duration of labor and pain relief option available. If all this must be explained to her beforehand, before. And we have, Foxy GCPR, which has a patient information sheet, which has a consent form. It has a checklist. So we all must use all these things when we are inducing. So the general principle are cervical stasis has to be assessed, and the condition of the patient, and her general condition, her any previous surgery, any medical disorder will guide you what method of induction can be used. Like we can't use misoprostol or prostaglandin in asthma patients, and we can't use prostaglandin in previous cesarean patients. And you have to be very cautious. Facilities should be available for maternal and fetal well-being, and they should never be left unattended. And if it is failed induction with one method, does not mean that you have to do cesarean. Suppose you have given mechanical method, and after that you can sequentially use another method. And it should be carried out in a place where cesarean can be performed. And the increase in the cesarean rate because of induction, if you look at that, there was a ARISE study in which they did inductions at 39 weeks, and they found that whether they're doing elective induction or leaving the patient for elective delivery at 40 weeks, in low-risk women, there was not much difference. So it is how you are doing induction, how you are following, what method you are using, what you are calling a failed induction, whether you're providing pain relief, whether you've given enough counseling, that is responsible for most of the failed inductions and cesareans. The cesarean rate for inductions are not higher because of fetal distress or hyperstimulation, unless the induction has not been done properly. Thank you.
Over to Dr. Meena. Madam, you're muted. Madam, you're muted.
Thank you, Dr. Achla. That was a very comprehensive talk on induction of labor. I know this is another topic which generates a lot of, passion when talking about when to, and we all seem to have our own indications. And because it's on optimizing labors, this is another area that we have to look, not only look into that, but also, as you specified, we have to be really clear when we are saying, ripening of cervix, and how important it is to do a cervical, the old practice of sweeping for the membranes, so that they spontaneously, if they are allowed to go into labor, all the more better, and our induction rate may come down. And that numbers needed to treat properly is 1 in 8, but then that is so good. We are, doing away with some pharmacological method. And then again, you told us when to specifically say it is failed. So many satisfaction, or she sees other patient crying out in labor, and then she has a cold feet and says no, and we would like to say it is a fail, but it's not. So thank you for highlighting all when to say failed, and also give it a full try, and we can go for sequential methods before calling it a day. So it was a wonderful talk. Thank you.
Yeah. Surely, and the word about the labor analgesia, that's so important. If you're inducing, definitely she's going to have more pain. I've seen that with misoprostol, the induction is really good. But there is a lot of pain. Though, so we have to think about that also. Epidural analgesia may not be available in most of the places. However, other pharmacological, non-pharmacological, birth attendant, and all those things, if we can weave into, I think we'll be having more vaginal births. And definitely the point about failed induction is really good. And the Indian setup, Dr. Achla, I would like to highlight that also. 39 weeks in the post-dated 39 weeks we want to have inductions, isn't that? I think the Kerala Federation has its own guidelines, and they are advising inductions after 39 completed weeks. So again, this
If
is
you
a
have to want
point
to
of
wait, then you have
contention.
to be very
Yeah, it's a
vigilant.
point of contention, I must
90.
say. Yeah. So this is one point where there is a lot of chance of debate, I understand. But yes, once you go nearer 40 or beyond 40 in Indian context, the risks are increasing. That is what is seen. And that's why probably that debate, some states, this KFOG, that is Kerala Federation, is advising, but other states, I have some few faculty who are saying, no, we don't want to do it at 30, so 39. So there is a lot of debate around that. So what is your thoughts, Dr.
At least we
Ashla?
must sweep and stretch if possible
Yeah,
at 39.
sure. So sweeping is one of the things. So if
Or
we
ask the patient to have intercourse.
Yeah.
okay,
That
and
works like magic. That works almost like sweeping, stretching, because prostaglandins are released.
and
It
another
also
thing, I don't
allays the
know.
fear, and they start enjoying. It's a group activity. I find that really very effective.
And
Small.
I also wanted to inform you about one thesis work research which is going on in our department, and that is about isosorbate mononitrate. It works like magic, this year only
I have also done
yeah,
a thesis on isosorbate mononitrate,
So
but yeah,
only
but
misoprostol
they are
or
still
misoprostol plus
experimental.
isosorbate mononitrate, and she is beautifully progresses, and I
Please
think
share
that
the link,
also.
Sureka.
I think we
Yeah,
need
yeah,
Share the
more
link.
data before
Mononitrate,
we can
isosorbate
conclude.
mononitrate, and
Yeah.
again works like magic. So we did have a discussion on ProPES also, but some of the centers are saying that there is a lot of hypercontractibility with that. So we do have so many methods. ProPES is very costly also, we know that, but one state, I think Telangana, is providing it free in the public sector. However, I think from our experience of last 6 months of isosorbate mononitrate, I think that can also be considered of one of the methods.
But
So
that must
maybe
be
we
still
need
वे
more
हमारी
clinical
FDA
record
अभी
of
we need
misoprostol
more
कोई भी
evidence, we
दूध
need
दे रही
more
तो
FDA. So that is only in the research setting. So if we are
yeah.
talking of uniform guidelines, then definitely what Dr. Achla has said is absolutely what we can look forward. And she's also heading the group which is looking after this intervention in our LSCS optimizing LSCS project. So thank you very much, Dr. Achla, for leading us and guiding us through this very important topic.
And Dr. Surekha, I wanted to ask Dr. Achla which group her daughter-in-law falls in. Primary, multi,
She was induced, I think.
Induced, so either she is 2 or 4.
Primary induced, second
So 2.
stage
She's 2.
discovery of occipital posterior, and
Oh,
then
you gave her a
Oh,
very
that's sad. But
But all
still,
the
I
best.
mean, you tried your best
Congratulations.
to have her
Yeah.
vaginal
Group
delivery,
2,
and we
group
must
2, but
congratulate
fair
you.
too, fair too.
गाली
So what
पड़ेगी
she
मुझे उससे?
preaches, she does. Yeah, that's important. So thank you and congratulations to the
Thank
whole
you.
family.
Yeah,
Dadi.
thank you.
The
Yeah.
Dadi.
Thank you.
Thank you.
Congratulations,
Yeah.
Achla ji. Congrats.
Thank you, Ji. Thank you.
So over to Rashmi. Can
Yeah.
you introduce the
Thank you, Ji.
panelists?
Thank you.
Thank you, Manu. And Dr. Nivedita, would you
Yeah,
like to
yes.
explore from this?
Could you reflect Surekha ma'am CV? So it's
Not
really my
mine, not
honor
mine, please.
and
Not mine, please. Yeah, please go ahead. Oh,
okay, she's
I
our
want to
boss,
say one thing, she is the principal. She's our principal here.
and it's really we are very lucky to be working under ma'am in clinical research committee. So
Yes, yes.
okay, has been not to introduce her. We'll go to the panelist straight. Vidya Thubi ma'am is there. Welcome, ma'am, on board. Vidya Thubi ma'am.
yeah. Yeah, you can introduce everybody briefly, please.
Yeah, because next Vidya Thobi ma'am, she's held up in some meeting, so we'll come back to her later. Can we go to Sampath Kumari ma'am? Ma'am is there? Yeah. Good evening, ma'am. Welcome. Ma'am is present Vice President of Foxy. She's a Senate member of Tamil Nadu MGR Medical University. She's been National Corresponding Editor of Jogi. And ma'am is a retired Deputy Director from IOG, Chennai, Madras Medical College. She's a celebrity in Foxy, a very hardworking and very respectable in South India. Welcome, ma'am. All over India. Next, my favorite Meena ma'am. I had honor and privilege of working with her in the previous Foxy Clinical Research Committee, and I have learned so much from her that never get stressed out, never speak loudly, never shout out, and she has a very good, beautiful way of getting things done. So such thing, her calm composure, everything speaks for her. Ma'am is a senior consultant and head at Kurji Holy Family Hospital. She is the present president of Patna Ops Gynae Society, and ma'am is also one of the principal investigator in our Vishesh project.
Thank you. It's all I've been introduced before. Thank you. Nivedita.
Welcome, Shobha Gudi ma'am, another of my favorites. And ma'am is a professor professor and head at Saint Philomena Hospital, Bangalore. Ma'am is also very hardworking, and she is renowned, and she's heart of Foxy. She was recently in our Foxy Femtech LSCS consultation. We worked together on the CTG module. Apart from that, madam has been the president of Bangalore Society of Ops Gynae 1819. She's assessor in the Government of India project Lakshya.
Yeah.
And many things to the credit of ma'am. Welcome, ma'am.
Thank you.
Our next panelist, Professor Girja Vog. She's professor at Bharati Vidyapeeth Medical College Hospital, Pune. Senior consultant at Cloud9 and Apollo Hospitals, Pune. And ma'am is also faculty professor at OGASH International Experts and general coordinator. She was in 2016. Madam has been vice president of Justosis India chapter, also governing council member of ICOG, and there are many things. She is a great academician, and we had opportunity of meeting ma'am in Pondicherry. So apart from many other places in Pondicherry, directly I have interacted with ma'am during Justosis conference. Our next panelist. Yes, Charmila ma'am. Ma'am is the one who introduced me to this Foxy Clinical Research Committee, and every day, ma'am, I'm very thankful to you. So she is the Vice President-elect Foxy coming, Chairperson of Clinical Research Committee 2016-18, ICOG Governing Council member, National Coordinator of UNICEF and Foxy PCA. Ma'am is also National Coordinator of Medha Foxy PG programs, ISAR Gurukul, and she's also a WHO CRO MDSR India member, and many, many other things. Most things, she's a very dynamic and always smiling. As her name says, she's really very charming. Charming Charmila Yavu, ma'am. Welcome.
Thank you, Nivedita.
Next, Dr. Revati Rane. She's director at Multi-Speciality Apex Hospital, Akluj, 10 years. Also director of the first rural IVF center in the area of Akluj Fertility Center. 5 years. She's been associated with lots of social and community work. Currently, she's Vice President of Akluj Obsgynae Society. And she has held many posts in local societies and also very active Foxian. And interestingly, she is the winner of Medic Queen Miss Maharashtra Season 2. So welcome, beautiful Dr. Revati.
Thank you. Thank you, ma'am.
Yeah. So thank you very much, Nivedita, for introducing our very, very accomplished panelists. So when I look at the panel, I feel overwhelmed. Okay, so am I going to be able to moderate with so many accomplished people? But definitely, I think we would have more to hear from their experience when we talk of this panel on optimizing C-sections. So let me share my screen first, and I hope that other panelists will also join us so that we have a good discussion. So our panel today is on optimizing C-sections. Is my slide visible? I don't know.
Yes,
Yes, it is visible.
I'm able to see my... Anyways, I have to stop share and share again because I was seeing my WhatsApp. Okay, I'll share again. Okay. Here it is. So our panelists have been introduced, and I definitely would like to share the background that cesarean sections in ancient time was conducted on mothers who are dead or dying. And, it was associated with high rates of pain and infection, and the mortality rate was very high. Over the years, with improved anesthetics, surgical techniques, antibiotics, we have found that all these infections was reduced, and we found a good a reduction in maternal as well as neonatal morbidity and mortality with the use of cesarean section. But we know that cesarean section is a life-saving surgical procedure that has significantly reduced maternal and neonatal mortality when medically indicated. That is the word. We have to underline it. However, we have seen over the years its use has risen for various reasons, and sometimes we find that it may not be medically indicated at all. And there are a lot of disparities when you look at the geographical reasons, public versus private, rural versus urban, and we find that this increasing in cesarean section over a particular rate has not been accompanied by clear health benefits to the mother as well as the baby. And many of the women may lose the benefit of vaginal birth due to this trend in rise in the C-sections. And clear recommendation. So one more thing is clear recommendation of what should be the optimal rate is also not available. So we definitely have a lot of things to discuss here about, So now, do you agree that overuse, that means use of cesarean section without medically indicated reasons, has a potential risk of harm to both the mother and the baby? So anybody can take this, but Dr. Vidya is not there. So anyone who want to take this? And what could be the risks? Dr. Charmila?
The risk can be to the mother and the baby, and there are both long-term and short-term risks that we have to understand. Short-term risk, there will be a longer stay for the mother and the baby in the hospital. So we're going to have a higher risk of hospital-acquired infections. And there are studies which say that the baby has got a higher risk of asthma and having an overweight as an adult when the baby undergoes a cesarean section. And as the mother, for the mother, we know there's always a higher risk of infection when she's undergoing a cesarean compared to vaginal delivery. And the hemorrhaging is also much more compared to vaginal delivery. And the risks are also like now we are seeing lots of scar ectopics and sequelae, which has not been seen earlier. With the increasing trend of cesarean, you're seeing more of these complications. And also there seems to be a higher risk of little infertility also when the adhesions are much more when there's an infected section. So the complications are not less just because the mother undergoes a cesarean. So we have to keep all that in mind when we are going for a cesarean.
Yes, the complications of anesthesia, the hemorrhage, and rightly said the scar ectopic as well as the placenta accreta. We are seeing such a lot of rise in this placenta accreta, which we used to never see earlier. So again, peripartum hysterectomy is, and this is one study which says 10 times more PPH, placenta accreta, and obstetric hysterectomy, no antibiotic use, longer stay, as you have already said, pain adhesions, and neonate also. So many problems have rightly said. So morbidity and mortality with C-section is 3 to 7 times higher. So that we have to acknowledge. So though we want to do it for the good of the mother and the baby, but we are finding that there may be a higher risk of hemorrhage, of extension, of bladder bowel damage, injury, DVT, embolism, endometritis. Cost, of course, is another factor, but when we are talking of clinical outcomes also, we find that there is a lot of concerns when we are talking of C-sections which are rising. Now, Dr. Shobha, from your experience, can you talk about these disparities? We are talking of geographical disparities. We are talking of a steep rise. And from your experience, you have been working in for almost 25, 30 years now. So what do you think is this steep rise is about and about these disparities which we are seeing?
Yeah, I think, Sureka, by now everybody is kind of on the same background, on the same stage. Everybody understands that this problem is actually multifactorial. Okay, there are many, many reasons why cesarean section has seen a steep rise. And in order to understand, I think we need to know that there is a change in the morphology of Indian women who are giving birth today. The adults are remaining the same size, but the babies are becoming bigger. So the average birth
We will
weight of the
talk
Indian
about the
women have
factors,
gone up.
madam, but can we talk about the rates? Are you
Pardon?
seeing some? We will talk about the factors,
Yeah.
definitely. But we would like to
One
talk
minute.
about this
Somehow
disparity
I'm
of
not
rate.
able to listen properly. Tell me what
Yeah,
do you
we
want
will
to
be
know?
talking about the factors, the determinants.
Yeah.
Definitely, presently, I want to know what is the difference in between the rates, the disparity which we see in some state is something else, another state it is something else. Public versus private, we find a lot of disparities.
Yeah.
We
So
are
I
talking
think
of
the
factors
disparities,
also. Why
correct,
there is such a
correct.
lot of difference in the rates?
Yeah, I think there is a very strong dichotomy of care for the rich and the poor in our country. That is the problem. And today, somehow, the corporate world has brought in a lot of, fanciful ideas about giving birth and all, and that has increased the rates of cesarean sections in these birthing units. The increase in rate in different states, I think one way of looking at it is where the birth rates are very high. Those are the states where more multiparous deliveries are happening. And therefore, we see a relatively lesser cesarean section rate, maybe in Uttar Pradesh and Bihar. At the same time, we know that there is a higher kind of adverse maternal and perinatal outcome. So that lesser cesarean is not exactly a good news from those states. They have to achieve optimal fertility rate, then only it will start making sense. But then the high rates in some of the states which is coming across is a lot of concern, and that is because there is a higher growth of, especially in the southern states, there's a higher growth of the corporate sector. That is one reason which I have already told you. The cesarean section on demand has been exceeded to, consultants are, every day they are also kind of getting into the game and they are also performing. And probably there's one more reason is, why the mothers are becoming pregnant at an older age, and high risk pregnancy, post ART pregnancy is also on the rise. So that is why there is a lot of difference which we come to see. There's one more factor which you are saying that factors will be discussed, but then it contributes to rate. So I must say the training of our postgraduates is taking a backseat because of the increase in number of institutions and a relatively lesser number of deliveries that they are exposed to. And simply they are not trained better in obstetric management, in instrumental deliveries. So the training in instrumental deliveries has come down. So probably that is explaining some of the inabilities that we see in the newer generation consultants who are very afraid of taking on any challenging deliveries, even if they are in the middle level hospitals or even in the government sector. If they are working, they feel it is safer to. And of course, the reaction by the patient and families towards the slightest adverse outcome, it frightens the doctors. So everybody is kind of wanting to complete the job with an abdominal incision. So that is the reason for the disparity. There are many kind of, and the differences
and
that
we
you
do
see
know.
probably are kind of guided by all these factors. Yeah.
Yeah, so we do. So it is not only in India, it's a global phenomena. If you just look at the countries, various countries also, you'll find such a lot of disparity. So if you look at these Nordic countries, you look at Netherlands, Finland, Norway, Slovenia. So just look at the C-section rate is 15%, 16%. And if you look at Mexico, Turkey, Italy, Korea, just look at it is around 50%. So even throughout the world, it is not only in India. So you have rightly pointed out the southern state, and Jammu and Kashmir is one which I found is quite high. Haryana, Punjab, I think these are the states which are highlighted in the dark. And we do know that in certain states, Dr. Pawan Kumar had highlighted this, in certain state it is quite low also. So we did find that he said in Nagaland it is very less. Jharkhand, it is very less. Tamil Nadu, it's quite high. So there is a lot of disparity. Maybe, as you said, the training is affecting the economic conditions, the corporate culture. All these things are definitely, affecting. And this gap we find, and especially when we are talking of rural and urban, especially when we are talking of public and private. Again, if you see, even in states like Bihar, you are seeing that there is a lot of disparity between public and private. Similarly, in Telangana, you see that the C-section in public is 40% around, and it is 75% around in the private setting. So we find even in Jammu and Kashmir, you find a big disparity between public and private, and that is really going to make a difference. So I have this question for all of you. All the panelists can comment on this. What is the ideal C-section rate? 15%, 15 to 25, 25 to 40, 45 to 40, 60. What do you think? Each of you can comment. Dr. Meena ma'am first. What is the ideal according to you?
There's no ideal. I mean, we cannot go by the rates. We have to actually look at our population, the indications. We have to be right in taking the right decision. That is more important rather than focusing on the rates. But I mean, if we go by the rule of nature, what we are built, the way it goes, normal delivery is the right thing to happen. But then we all know that that doesn't happen.
Shobha, can you mute yourself, please? Dr. Shobha. Shobha ma'am को आप कोई mute कर सकता है? Because I am sharing screen, I cannot.
Yeah. So what is ideal today may not be ideal tomorrow. So that is something, rather than looking at one rate, we have to go by what we are doing and why we are doing. That should
in your setup, madam, can you have
in my setup, which is a private setup, and you rightly said that in private setup it's pretty high, and in my setup, around, let me say, around 30 years back when I joined, it was still pretty high, but just nearing 30, and since then it has been only rising and rising. And one of the most important causes the previous cesarean section, and once the primary goes becomes the previous, it becomes. But having said that, no, it's not really. The primary cesarean section rate has also gone pretty high, and it's about 50% in my hospital.
Yeah. So it's 50%, but you do want to decrease it. We do know that though
Yeah.
there is no ideal rate, but we still have to have something, some goal.
Yes, yes.
Yeah, because
Yeah,
RCAG
I
saying
think
there is no such thing as ideal. We cannot quote a number, but still, from our own experience, from our own audits, from observing and auditing our own processes, we do know that it has to be reduced, and we are not
Surekha,
happy with 50%, isn't it? So we do.
Surekha, if it is 30%, I think we are closer to a very kind of, to a service which is pro natural birthing, around 30
Dr.
to
Sharmila,
35%.
you are in a private setup. What would you like to say about this?
There's no ideal rate at all. And when no other specialty has a rate for their conservative and other surgeries, I don't think we should have a rate at all. It doesn't make any sense at all. It should be maternal and fetal health to be taken care of.
That is very true.
No rate.
Surekha, can I add
I will
here?
not mention any
Just
rate.
a minute. Let Charmila finish. We will talk with Dr. Revti, and then we will come back to you, Shobha ma'am.
Yeah.
There's nothing like a rate. It should be a delivery which is safe for the mother and the baby.
Correct.
So don't put it into groups at all. And we should actually object when they say that we should have a rate. Because in cardiac surgery, do you have a rate? Do you have a rate in nephrology? Do you have a rate in urology? Nothing like that. So why should they come into this domain and create rates? Because the mother and the baby are of paramount importance. If you put a rate and you kill a baby, is that justified anywhere? Nobody is going to accept that.
No, but I don't agree to the word kill a baby at all, because we are all working for the safety of the mother and the baby and keeping safety in mind.
A politician or a setup should not tell us this much rate you should have, because I take the health of the mother and the baby of paramount importance when I'm managing an obstetric patient. I don't do it unnecessarily. So somebody telling me like this much rate you should have to justify you being an obstetrician is not acceptable at all.
Dr. Revti, your comments on this, please.
Yeah. Yes, ma'am. I feel WHO has told us to get the rates up to 15%. That is what they're suggesting us to do. What I feel, as everyone is saying, that a particular number cannot be quoted, as because everyone has a different obstetric population and the healthcare facility is also different. But again, I feel that we have to look at our practices also. We have to see what we can do, because we have discussed about the number of increase in acritas and scar ectopics, and we know that in some of the health facilities there might be unindicated sections going on. I don't want to point fingers at anyone, but we have to introspect, and we have to see if we can lower our rates and have better, we have to find a mean in this. Yeah.
Sure. So I agree to that, and as rightly said by Dr. Shobha ma'am, it's about the training also. If there are only 90 days, so even in my own setups over the recently in the last few months, I have seen such a lot of change in my own setup. So there were only 90 deliveries per month, so high C-section rate. As the number of deliveries started increasing, as the training started increasing, as the confidence for vaginal delivery started increasing, so we now have 200, 250 deliveries. Now we find that the vaginal delivery. So there are number of determinants. We have to introspect. We have to look at our processes. And yes, we have to do something about it. So introspection is very, very important.
Yeah.
And we do know that this is the recommended rate, but we no longer agree that 15% is ideal. But
Correct.
if we have an alarming
that.
rate in rise, we definitely have to look at our processes. We definitely
कुछ बोल
have to
सकती
find
हूँ
out
अभी?
what's happening. Yeah.
Can I say something, Surekha, now?
Yeah.
Yeah, I agree with Charmila that rates, we should not commit to any rate that we'll give this rate in our institution, which will be wrong. It is not patient friendly. Every woman who needs a cesarean should be safely provided a cesarean. That is what is the principle with which we are working. Okay. The problem is that the indication should be sacrosanct. And then that is something kind of at an obstetrician's personal level. Each one of us have to see that we really do it with a very correct indication. If we do that, then that itself will bring the section rate down. Now, there is a very important reason today why we have to kind of maintain a certain rate and do a regular audit and submit it. Because I feel that they are going to look into cesarean section rate with a lot of vigor post-election. And I think there is going to be a demand that the section rate should be brought down, because I think we all know that there are too many unindicated sections happening today. It may not be happening in your hands, it may not be happening in my hands, but definitely the obstetricians of India today are performing far more cesarean sections. And somehow Foxy has to take some responsibility, because we are the academic organization or a standard setting organization for all our members. So therefore, we will have to say something about reducing cesarean section rate by at least 10% of what it is today. I think we will have to strategically work towards it. Otherwise,
we have to agree,
some
Shubha
problem
ma'am.
will come. Yeah.
Yeah, we have to agree, Shubha ma'am, that if we are talking perinatal mortality and its association with C-section, so after a certain rate, we don't have any advantage as far as
Definitely
perinatal
not.
mortality
Definitely
is
not.
concerned,
That's
as is very rightly
Mm.
depicted in this graph. And because
Yeah.
we are not adding many benefits,
Right.
to cesarean section. And that's why we now come to this question, that when analyzing these rising trends, and you have quoted so many factors, what could be the common indications for which C-section delivery is now being conducted? Do we have Dr. Gurija ma'am here? If not, we can go to Dr. Meena Samant here. What are the common indications you encounter time and again, day after day?
Yeah. So I will leave the previous cesarean section, because most of us would be doing it for that. But apart from that, in a primary, in a non-scarred uterus, if we look at, then failure to progress or the labor dystocia is one common indication. Then we have even fetal distress, the presumed fetal distress, or the CTG, what interpretation is another thing. Then that the baby may be a little bigger, not able to negotiate through the pelvis, that kind of a thing. Maybe that is also related to dystocia. And also malpresentations, be it shoulder or breech, whatever. So those are other common factors that we see in our practice, apart
Yeah,
from, of
so
course,
we
previous
have
cesarean. And now another thing is, with the previous scarred uterus, those previas and the cretas, they have increased. And not only the cesarean rate, but obstetric hysterectomy rate also seems to rise.
So 70% of the indications are for what you said, a fetal distress, which is presumed. Actually may not be a fetal distress, but the tools which we are using, or maybe the apprehension also labels it as a fetal distress. Repeat C-sections are, of course, are risen exponentially. The breech, and as you rightly said, dystocia. These are the 4 indications which are contributing to 70%, and where we can work, maybe the interventions can be. So Dr. Sharmila, what are the drivers? What are the determinants? Your experience from your setup, and maybe from the, private and public, both we can have two together. Yeah.
Actually, COVID taught us a very, very important lesson in obstetrics. We had very less inductions. We didn't go and monitor the fetal heart rate again and again. We just waited for the mother to progress into first stage. Then in second stage, you also waited. We didn't want to get her infected, or you didn't want to get infected, all that. And we had more of vaginal deliveries. So I think that should translate into practice. Like, induction should be reduced. Do not have too many inductions. And then the diagnosis for labor dystocia, which has been altered by American College, should be accepted, not fully, but at least to a point. Because don't rush from, like, so a patient is like at 4 centimeters, don't rush into augmentation. Just wait for her to progress to at least to more, 5 to 6 centimeters. Use oxytocin judiciously. That thing should be there. And the other characteristics, like, as you said, fetal distress the diagnosis should be like, it should not be taken off the, just like looking at a heart rate and saying it's dropping and just take resection. It's not necessary at all. You can do some resuscitation for the mother. Many times they settle down. So your definitions of labor dystocia, fetal distress needs to be in par with
My
what
question
the
to you,
guidelines.
Dr. Charmila, drivers. I have many times in the newspapers and all, we see financial incentives, they say, is one thing. Then maternal request is another. High maternal age. Do you find such thing in your setup?
Yeah,
Or
I am.
you can observe around you that maybe the obesity is increasing, the higher maternal age, IVF, changes in clinical practice. What we used to do earlier, we are not doing now. We are not using the forceps, and we are not, the training, the transfer of the skills is not happening. That is one thing, I think. And maybe fear of pain is one. Women don't want to go into labor because they fear that intense pain. Even I have seen multi-gravidas who have had previous vaginal delivery now will request for a cesarean section because she remembers her pain and lack of analgesia. So I think these are some social as well as clinical drivers, and and fear of that childbirth, some experiences maybe of disrespect and abuse in her previous pregnancy. Sometimes in public setups, just she remembers what happened in her antenatal care, and she's fearing maybe if that's kind of care if she receives during her intrapartum period. All those kinds of things are and of course nowadays we also see that muhurta C-section, as Dr. Mitra has labeled that in her GCPR, auspicious birth date. Even all these things we are observing in our own in not our setups, our surroundings. We are seeing so many things which are adding on, apart from the factors we have already talked about. So
I'm attached to, my hospital is an IVF center,
mhm.
but I'm attached to railway hospital where the financial incentive is not there at all. So vaginal delivery or cesarean, they need not pay. So there's no financial incentive. Still, we have got a higher rate of cesarean in railway hospital, and that's because major is obesity and older mothers. Most of them, employees, they get married later and they come with obesity also. That was a big driver in the setup in railway hospital, and there's no financial incentive there. In my setup, it's more of obesity everywhere. Reasons for infertility,
Obesity, higher age,
major reason.
diabetes, this could be IVF pregnancies are on the rise, but there are
IVF pregnancies also, I don't do a section per se. I try to go for a vaginal delivery.
Yeah, but I have an IVF center within my setting and 100% cesarean section.
No, I don't do. If it's a male factor, she's a young age.
We have a lot of diversity in the thoughts, in the processes, in the actions. And that's why I think the uniform criteria or somewhere some guidance, some discussion is very, very important. And there is one study which has quoted that most of the C-sections happen during the working hours. So before the clinician leaves the hospitals, he or she wants to finish the work. It peaks during the weekdays and specifically on Fridays. So Saturday, Sunday, probably they want to finish. So there are so many, such a lot of work has been done. And so we really have to agree to
fear of litigation is actually a very, very important
high.
point.
So very definitely high. When we were having this LSC's consultation, I talked about this very, very vehemently that we have to have support from the government. If we have
they don't support.
They don't support. So we, as a FOXY, as a leading organization, we have to work on this also, that the government supports us when we have this fear of litigation. So something has to be done on this.
The government here in Tamil Nadu has a maternal death review, and there they actually harass the obstetrician. So, senior obstetricians sit and cry during the maternal death review. The way they talk is so demeaning and humiliating. And anybody would rather go for a cesarean to get away from that.
And when we are talking of optimizing C-section, we have to stress on this also. Definitely we work on this, but there can always be a mishap. So we have to have support. Unless that support is there, that strong support is there, then your obstetrician are going to conduct these cesarean section if they think that yes, it is safe fine, let us get it done with. Because if there is no monitoring, something happens in the night,
See,
it
Sureka,
can
there's
happen.
only one point. See, only one point. Sureka, one point. Always talk about respectful maternity care at all. In any review in Tamil Nadu, it's like so complicated. People are just like thrown under the bus if something goes wrong, and nobody is there to support. She cries when she comes out of the audit. So that also you should mention wherever you're talking about, because in few years, probably in the next generation is not going to take up obstetrics and gynecology in Tamil Nadu. That's going to happen.
Yeah.
That's
I
a very, very
agree to
strong message.
that. And definitely when we were talking of this panel going on and we had government and UNICEF people, I was stressing time and again that please look at this support. If the fear and apprehension is there in the minds of the obstetrician, any number of any amount of work we are going to do on this is not going to help. So
No.
definitely we do have to support our own people, our own obstetricians, our own healthcare workers to find that safety in their minds. ये mishap तो हो सकता है ना. Best of the centers also can have a mishap. It is not that we are trying to kill something or we don't want to save delivery. Our intentions are always good. So we have to have support from the government, and definitely we have to push this point as well. So Dr. Meena, what could be the broad strategies from your side, keeping into mind that we want to reduce, but we want to be safe as well?
Yeah, like I would, start from where you just stopped. That is the government supporting us, because litigation, because any delivery, whether be it a vaginal or a cesarean, can be difficult and we can land up in this thing. That is something the patients have to understand, and the government has to support. The other thing I would say, the patient herself, if the patients and the attendants understand, and they also, because they give us a lot of strength. Because once just I was recounting this thing, when a breach we had last month, we had 2 vaginal breech deliveries, and the patients, they did not want and they were well into, one of them came well into advanced labor, and they said, no, we understand, now we want a vaginal delivery. So the patient accepts, and the patient's training and counseling from the antenatal period itself can also give strength to taking decisions. And because now the trend is, the patient comes, I want cesarean. But we can also, guide them where they say we want cesarean, and they also take a part of the responsibility of having, because complications can occur both the ways. So the patient factors are important, and we can also work in other things where, like you said, patient factors can be addressed. And the other part is our own training. Training is important. When our residents are allowed to take decision, it should be supervised. They have to take it, get it endorsed by our seniors, and also so they know the decision. They know that they are also under scrutiny, and the decisions that the indication is being supervised. That is one thing. And of course, like you said, audit is something very important. We all have to do an introspection. And like the other party who are accusing of so many things, they are not totally right, and we are also not totally wrong. So there is a balance, and we that can come through our own audit. And no one likes to be, pointed out from outside. So let's do it. And the project that you have taken and started under Dr. Pai of auditing is something really great. And I think if we seriously do it, honestly do it, it is going to help all of us.
Dr. Revati, there was one article or a project about the second opinion. And I would like Dr. Mitra also to comment on this. So there was a recommendation that each and every C-section should have a second opinion before going on to. So what do you think in our own context? How easy or how difficult or how feasible is this? And what is your, they have quoted a very good literature and decline in rate when the second opinion was taken. So what do you think in our setups? Can we do it?
I think when the situation is like fetal distress, so most of the times it might not be feasible, the obstetrician may not be available. Second thing is it is our branch is very subjective, I feel. So pelvic assessment, that is what I feel is we cannot prove that the pelvis is inadequate. We cannot. So even if the second opinion we are taking, so if we won't be able to prove that. So I feel most of the times it may help us, for us to support our co-consultants and to explain it to the patients and to be on safe on paper. So if that we are sure about our opinion, then we shouldn't have any issues regarding taking it. But it may not be feasible always in emergencies.
Dr. Shobha, you are the head of department. Yes, Mitra.
Yeah.
If
So,
Dr. Shobha is speaking, then I'll speak after.
Yeah.
Okay,
Dr.
okay.
Shobha,
Mitra, thank you.
you're the
Thank you, Mitra.
HOD. You have 2-3 units. And do you
Yeah.
think that if you support each other, there can be some, some change or some reduction or something can happen if there is a second opinion?
Yeah, I think practically speaking, I think many minds are working on this simultaneously now. All the panelists are thinking about the second opinion. So to begin with, I'm not saying that this needs to be always. To begin with, at least, we can have a group decision or whatever on the scheduled cesarean sections, on the elective cesarean sections, to kind of make it little more practical, because for emergency cases it is very difficult to get a second opinion. So at least, but a senior's opinion can be taken, because we cover our junior consultants all the time, and for emergency cesarean we always kind of see, but some doubt will always be there that I was on the place, then I might have given her more time. But then that is very difficult to achieve. Therefore, for scheduled cesareans, probably we can have a hospital policy of 2 people opining, because for how MTP in later trimester has, is always with 2 specialists, the same thing can be adopted, and it can be put on paper that 2 people have endorsed this scheduled cesarean section. That
Dr.
is,
Mitra
having
and
said,
then Nivedita, I
yeah,
think.
Yeah, actually, I would like to say something that having gone through all the 10 groups, we have to understand that some groups are non-modifiable. For example, already all the breaches, it's not just us people. Our patients don't give us an option of doing a vaginal breach. So we have to understand transverse lie, breech deliveries, all are coming into nearly 100% incidence of cesarean section. So only places where we can do modifications are primies, multi, spontaneous labor, induced labor, and previous cesareans. If the number of VBACs will increase, again, you recount the complications of emergency, everybody will opt for elective cesarean section. So I don't think that second opinion, yes, on paper, because if we are not practicing correctly, the government is going to intervene, and that will be in the form of putting a roadblock. Otherwise, in ideal circumstances, you really don't need a second opinion if your decision making is appropriate. Having said that, but this is only possible when you are working in a unit. If you are doing standalone, you have to justify your cesarean section with the patient, with the relative, with your own documentation. So like Revati said, fetal distress is a place where you're taking an opinion. And another thing is that this option of second opinion has a very high disunity also. I mean, you cover your colleague who you presume would have taken an appropriate decision, because we all
Mitra,
know
I just want to intervene here and bring in Dr. Nivedita.
Yeah,
Because we
so
do
I
work in
think,
units, and
I think we
we
have
do
to
have lot
improve our
of
practices.
covering with each other. They are also, we are covering our associate professors, so we are covering our assistant professors. So they are early career, but they do have experience. But still, there is a second opinion in the form of a second on call. So Nivedita, what do you say about that?
Second opinion definitely has a role. Though seniors covers the junior, and as Shobha ma'am said, for elective section. So elective section is decided by the junior consultant, and senior always oversees. It is documented on paper. So elective section has second or even third opinion. It goes without saying. But yes, in emergencies also, ma'am, we try to provide at least during office hours as much as possible, especially in cases wherever CPDs. Caesarean is taken for CPD. So we come and we reassess, we do, whether it will cervix dilatation, whether cervix is fitting or not, whether further augmentation has to be done, molding and position, all that, all these skills, it comes with practice. And then again in second stage Caesarean section. So there also we pitch in whether really second stage, we try to save second stage as much as possible, whether instrument can be applied, or it may be a wrong decision to apply instrument and you take for cesarean delivery. So in certain conditions, second opinion matters a lot. Again, for fetal distress, so you can share the picture over WhatsApp, and then we can say, okay, it's like this, you can wait further and or do research, intrauterine resuscitation, but not always, and it may not be feasible all the time. That even I personally feel, because
but as rightly said,
standalone, it's not possible. But yes, for institution, it's okay. It's good
standalone. It is fine.
Even for single practitioners, you get an opinion from somebody, Mitra madam. It's very, very easy, and not easy, I'll say safe for you, because somebody gives an opinion regarding like whether what you're doing is right at that, because you'll be so stressed out being with that patient for such a long time.
Very
and
soon
somebody
it's
comes
going
in
to
fresh,
be there,
somebody
so we
comes
will
in
be
fresh
doing
and
it.
tells you, no, madam, somebody comes fresh and tells you what you're doing is right, or just move on. It really helps, because we have a buddy system like that. Anytime in the day or night, I go to help her and she comes to help me. It definitely helps us, because
Madam, here, madam, here,
takes away your stress at every point of time.
And ma'am, I would like to
just a
add
minute,
something.
Revati and then Nivedita.
Yeah. I'm the junior most in the panel, and we are very less exposed to the instrumental deliveries and everything. And I'm very fortunate to have my mother with me, who didn't even have ultrasound when they were in. She has her UGPG from BJ, so I'm very fortunate to have her with me. So I do call her whenever I feel, they used to apply mid cavity forceps, rotational forceps. So I do call her. I do take her opinion because they're extremely good with all their rotation and pelvic assessment and everything. So in my case, I think with my personal, because my learning curve, because obstetric also has a learning curve like laparoscopy. So my learning curve has been better with her knowledge and with her experience. So opinion regarding primies, where we can, we are targeting to reduce the cesarean section in that class. So there the learning from seniors and their opinions will definitely help us.
Surely. So I must pick that one word from Dr. Charmila, and that is the buddy system. So it is not only in institutes, we keep on doing it now and again. The even in the night, the CTG picture will come to me, madam dip हो रहा है. अरे भाई इसमें dip है ही नहीं. या फिर we just counsel them, you don't worry, nothing is going to happen. So even that, just counseling them, it works. And as rightly said, second stage में juniors घबरा जाते हैं. You have a associate professor standing by the side, experience, who know she will, just deftly apply the forceps and the baby comes out. So many times it happens. So does matter. And I must take up that word from Charmila, buddy system. Revati, you rightly talked about your experience. So I think this is going to come in trend now. Like Dr. Mitra said, if you don't do it yourself, the government is going to push it from above. Like the PCPNDT Act, अपने ऊपर बैठने वाली ये चीजें, तो might as well we start doing it ourselves.
It is going to.
Yeah.
Sureka, can I have an input here?
Yeah,
Can I have an
please.
input? Yeah. So I had a couple of things to share. One is that, this cross consultation and taking second opinion, buddy system, everything is actually well appreciated. And we must practice it more and more. The thing is, going forward, the strategy for each of the Robson's criteria has to be different. Bringing down cesarean in each group, the strategy will have to be different. This is what I was trying to share as a one-on-one with Dr. Pavan also. So he was also saying, yes, that is making sense. See, Surekha, there are today a definite large cohort of women who are having a single known scar, transverse cesarean scar, okay? Very large cohort. And if we have to effectively bring down the cesarean section total rate, we must look at bringing it down in this particular cohort also. Because if this entire cohort goes for a repeat cesarean, that adds to the incidence like anything. Okay, so you have to have a strategy, a plan. Specifically, Foxy should give some specific training for VBAC, both infrastructural requirement and training, etc. Everything. That is one thing I wanted to say. The same thing goes for the group for induction. The same thing goes for the group for fetal distress. And in that, I had to share that when it comes to fetal distress, picking up on CTG, the best thing that can be done is to share the CTG on WhatsApp. And many decisions are averted when a senior looks at the CTG. Okay, I think that is commonly being done in every group. I just wanted to reiterate here.
Yeah,
The
and
third
even
thing
the breach,
is,
even the breach.
yeah,
Can we look at some antenatal interventions like
we
like
must
an
look at
external
external
cephalic
cephalic
version?
version
That
and training
skill is
for it.
again
And
going
training
in
for it. Yeah,
obsolete. We are not so
correct.
people. If you do an external cephalic version in the OPD, the ward, there are 10-15 people coming running
Okay.
to see how it is
There
done
is
because
one
it's not being
last
done at
point which I
all.
have to add. There's
Yeah.
one last point I wish to add, Sureka, please. One last point, and that is maternal request. See,
Yeah.
we have to understand why they are asking. And I think it is the fear of pain. And today they see a lot more of women laboring on the internet, etc. And so they get terrified and they read about the after effects on the pelvic floor and also everything. So therefore, some of the counseling which we do during pregnancy should go towards this mitigating this fear. Okay.
Yeah. So
And
that
maybe
brings us
the
to these
midwifery
non-clinical
led system.
interventions. Yeah.
Correct,
Yeah.
correct. That has to improve. But upfront, what we have to convey is that cesarean section is not without complications. Today, what is happening is they are thinking of it as an easy way out. You know, they are feeling that it is simple surgery and they are feeling, oh, so many people are getting it done. So it must be something safe and simple. So that message has to that myth has to be dispelled. That has become a myth today in obstetric practice, that women feel that cesarean section is the easy way out, whereas it is quite a hazardous
So we
surgery.
do have these
Yeah,
trainings of
correct.
midwifery,
Correct, correct.
childbirth training workshops nowadays, natural
So women
birthing.
must understand that it is not it has consequences later on.
Sure,
I
sure.
think they don't
And
understand
I
that.
think
Yeah.
we can talk of these WHO recommendation, childbirthing training workshop, nurse-led applied relaxation training program. So I'm not saying that everything has to be done by the midwives. There has to be a collaborative approach. But yes, we do need to work on these things as well. Relaxation techniques, psychosocial couple counseling. We are probably not doing it at all because of the public sector having such a lot of antenatal patients, such a lot of delivery workload. So we do have to have one cadre which can really take this task shifting towards the nurses who can so this fear of pain, information sharing, normalizing the reactions of individuals. So there are a lot of interventions which have been advised. Like you said, you have to really work on that fear factor. So if that fear factor, if we can work, probably rest of the things can be taken care of. So these are what the WHO has recommended, and certain things are about second opinion, has mandatory second opinion. WHO is saying mandatory evidence-based practice protocols. Are the protocols, similar protocols, being followed in all the units? Because definitely sometimes people go by their own fancies and they say, oh, this is my experience, but they don't follow the protocol. So all these things have to be and definitely the cesarean section audit, timely feedback, all these things are recommendations. And about this midwifery model of care, Dr. Meena, do you have any experience, or what do you think it should come in your setting, or how do you want it to be?
Yeah. Okay. Only I
Midwifery
think it
led
was
or collaborative, or what do you think?
all over the world there are various other models also, and recently it's making a lot of noise here because the impression people are getting is the doctors, the obstetricians, they are too quick with their knife and they just want to finish up the job, take out the baby, and for every other reason they want to take out the baby. Only I think it was 2 or 3 days back I was in a state level this sensitization meeting. So I think government is going ahead with the idea that they're going to bring in. I think they're doing in Vardha. They are doing training of the midwives, and there's a group of midwives from Patna as well. So they are being groomed to take over and take charge of the low risk patients totally. So it's something, it's going to be new for us. but only, I mean, I like our this thing says, no harm. So they have to be really careful. They're going to face the same music what we are. After all, we all are humans. So yes, there's a general feeling and belief they will try. They will do less intervention. They will be going for more physiological approach, and so they're going to have more vaginal
Natural.
deliveries.
So it's
Though
not
I
only
do not have
a
a personal
perception, Dr.
yeah.
Meena, it's not only a perception. There has been a lot of work done in various
Yeah.
countries on this,
Yeah.
especially
Yeah.
the Nordic countries. And
Yeah.
I would just like to inform all the panel that is now Foxy and UNICEF is holding hands on midwifery training as well. So it's because government of India is going ahead like anything, you know, for this nurse midwifery led. And you have in Gujarat, you have in West Bengal, in Orissa, in Telangana, in so many states. There all these midwifery, Vardha, as you know, it's the leading center where midwifery led units. Now you're going to have antenatal case papers where it is written not seen by consultant, it is written seen by midwife in bold letters. Everything they will write. Okay, so that confidence is being built up. But I definitely want to reiterate that it cannot be only midwives. There has to be a collaborative care. There has to be the obstetricians in the picture always, you know, because yes, if everything is going on fine, but if you want a specialist should always be there on board. And definitely you cannot have only midwives. You need to have an obstetrician in picture. Over to Mitra Saxena, ma'am. Before
No, I just wanted to say this, that it's very nice point that you have brought in, because I have worked in Saudi Arabia for 7 years. And believe me, all the normal deliveries, primaries as well as multis, were conducted by midwives, which were from Philippines. So in Philippines, the midwifery training program is very robust. They're not even nurses. They're just specially trained for midwifery. So basically, the process of de-learning that your ANMs, GNMs or nurses are trained to midwife, that's not the way. The way forward is you have a proper cadre of midwives only, and we also have to de-learn. It was actually a cultural, digression for me, that we were so used to doing with the vaginal delivery. Still, I realized that they are very capable to do the normal deliveries, even stitch the
they are
episiotomy.
capable, they are
We
more
would call them
patient,
only
they have
later.
less interventions, they don't apply forceps so easily.
Yeah, and
so we have to
the
accept these
respectful
things.
maternity care, which is
We have to accept, we have
Yeah.
to unlearn a lot of things. And once we start accepting, that is
the
where,
delivery cesarean
the
sections
reforms
will
are going to
decrease.
come.
But it
And
is
Dr.
going to take
finally,
time.
last,
Surekha,
we are coming to
whether
the
we
end of the
accept
panel. Let us discuss something about these financial reforms which have been suggested. You know, deliveries having less cost, C-section having high cost, and all of the media and everybody is behind the doctors कि उनको पैसा चाहिए इसलिए वो C-section करते हैं. So what do you say about this, Dr. Shobha, Dr. Charmila, Dr. Meena? Charmila is there or not? I can't see her.
No, she has an emergency. In fact, I would be leaving. I also need
Yeah,
to.
even
Okay, so we come to the final
Sureka,
take homes.
yeah.
Yeah.
हाँ मैं बोल दूं सुरेखा मुझे भी निकल हाँ, वो यही है कि actually we must look at uniform rates. That is
Sure.
what we must implement in our practice. There should not be two different rates. The only thing which adds on for cesarean must be the theater cost and the anesthetist cost
Yeah,
and
because we
consumable
need
cost here.
such a lot
But
of efforts go on in the
yeah,
vaginal births, isn't it?
correct.
So why
Correct.
should we charge less? Let's
Yes,
charge
yes.
equal, and then
So
maybe
we need to
this gets
equalize. We need to equalize, and
My
it is
humble
more or
suggestion
less
is
equalized.
when the
In the
doctor
corporate sector,
monitors
it is
for
equal.
longer time, more money.
Yeah. Yeah.
So,
In the corporate sector, it is
normal
equal.
delivery, where you induce, where you wait, you are justified in charging even more than a simple cesarean, which will take only 1 hour. So we have to decide.
But in general, Mitra ji, in general, I will also tell you what some of the past Foxy presidents have opined in the past. I don't know how it will become in the current perspective. In the past, in general, all of them would say that it will be prudent not to get into the cost factorization or whatever for services. Foxy usually does not talk about the cost factor. That should not be the functionality of an organization like Foxy. That is what I've heard them say. Even
This
the
can be
president-elect
individualized.
Dr.
Dr.
Jagdeep,
Shobha,
I've
this
heard
can
them
be
Public
say.
sectors,
individualized
we
and
don't
made
charge
popular.
anything, isn't it? In public
Correct. So he
sectors.
says normally
So
we do
it is
not get
free.
into the discussion
The
about
vaginal births and
cost.
C-sections are free, you know, but
Correct.
still, because such a lot is being said, कि ये
Hmm.
लोग पैसे के लिए कर रहे हैं, ये लोग पैसे के
Hmm.
लिए कर रहे हैं. So why
That
not?
we
There
can-
should be a
that we
cost
can-
parity. Cost
Correct.
parity is one thing we really have to talk about, so that we can deal with this all newspapers and the allegations which are coming up against the
Amongst all the problems we have discussed today, Surekha, this seems to be one which can be better achieved. I mean, a little with less difficulty. This
So
may
we
be
come
achieved with less
at
difficulty.
the end.
Yeah.
If any of the panelists don't want to add something, I would like to come up with this remark by Victor Hugo, that you can resist an invading army, but you cannot resist an idea whose time has come. And now the time has come for this optimizing C-section idea, in which we really have to take up. We have to wake up. We have to introspect cost parity, documentation, data collection, highlighting these things in the public domain. Our narratives also have to change, isn't it? So politicians, media, we also know so many politicians. We also know media people. So we have to bring our own opinion into the narratives. And yes, it is time to protect ourselves. Time to, look at our own processes as well. Otherwise, we know that another PCPNDT Act is brewing and is going to be pushed upon us. So before that, we have to wake up. We have to introspect. We have to commit to interventions as well. So thank you very much. And over to you, Dr. Rashmi and Dr. Nivedita.
Okay. Thank you everyone for joining. We have already crossed 25 minutes, but still lots of take-home messages today. The panel was flamboyant. So let me now take this opportunity to start thanking from first our Sir, Captain, our sweet Secretary General. Ma'am's words were very inspirational. Our ICOG Chair, Lakshmi Srikhande ma'am. Yes, we loved her words spoken. Mitra Saxena ma'am, whom I call, she's a foreigner, she's full of enthusiasm. And ma'am, you made the talk so simple and so comprehensible. Thank you for that. The talk by Achla ma'am. Ma'am, it shows your commitment and your intent to work for us. So thank you. Despite all that, you have delivered the talk for us. And to the beautiful panel, Meena Samant ma'am, Dr. Shobha Gudi, Dr. Sampath Kumari, Charmila ma'am, and Revati Rene. So thank you all. Every beautiful thing comes to end. And so this evening, we had a great time today hosting
And
you
I
all.
would like to thank Dr. Rashmi Kahar, who has done a lot of groundwork, who has done all the coordination, the flyer, everything, coordinating with everybody. So we wish you all the very best, Dr. Rashmi and Dr. Nivedita. Also, Dr. Jaya is there. She didn't speak anything, but all three of them did the coordinating. And above all, Corona remedies for all the support, technical support, which they have provided to us. Thank you very much and have a great evening.
Thank you very much, all the respected faculties. It was a great learning experience today.
Thank you. See you in the next event.